In case with obstruction, color Doppler will show turbulence at the LVOT. Notice also the SAM touching the IVS. Some cases of hypertrophic cardiomyopathy will present a gradient at the mid-ventricular level, not at the subaortic region. As you can see here, the region of ablation and greater velocity is at mid-ventricular level and not at the subaortic region. It is very important to distinguish this case from the ones with subaortic stenosis, since they are not suitable for alcohol septal ablation. As we can see in this case, there is an important IVS hypertrophy, and the mid-ventricular left ventricular cavity seems to obliterate right here during systole. This TEE shows it clearly in this transgastric lung axis. The cavity occlusion is in the mid-ventricle, not apical and not in basal region. The flow velocity are increased already in mid-ventricle. The hypertrophic cardiomyopathy with obstruction, when studied by spectral Doppler, shows this characteristic aspect. With systole, the gradient gradually increases in early systole. The myocardium has not yet obstructed the cavity, hence there is no high velocity. With continuing systole, gradually the IVS enters the left ventricular outflow tract and the velocities start to increase, reaching its peak at late systole. Very frequently, we will see a flow like this with continuous Doppler in patients with hypertrophic cardiomyopathy. While directing the cursor to the LVOT slide posteriorly, two peaks may appear. What happens here is the simultaneous demonstration of two different flows. The initial one is a mitral regurgitation that almost always exists when there is a left ventricular outflow tract gradient, and the final one is the late peak of a subaortic gradient. Doppler is demonstrating an initial part of the mitral regurgitation that moves out of the ultrasonic bin as the heart moves anteriorly during systole, and then the LVOT flow appears with its late peak. Here you see that a small posterior angulation, there is a perfect jet of mitral regurgitation, and with an anterior angulation, the mitral regurgitation gradually disappears, and now it is a typical dynamic obstructive flow. This is what occurs by directing the continuous wave beam at the dynamic obstruction at the left ventricular outflow tract. We may also demonstrate a jet of mitral regurgitation, and this is the resultant Doppler. Part is mitral regurgitation and part is LVOT obstruction. A flow with late peak but with low velocity, as seen here, may be found in hypertrophic cardiomyopathy in the LV apex. Then there may be two flows with late peak, one with high velocity at the left ventricular outflow tract, or at mid-LV when there is gradient in these locations, and one with low velocity in the left ventricular apex, even in case with no gradient. It is important to know that this kind of low velocity, late peak in the apical region, is not an indication of interventricular gradient and may be encountered in any important left ventricular hypertrophy, as for instance in cases of hypertensive cardiomyopathy or in aortic stenosis. This characterizes a left ventricular hypertrophy that intrudes a lot inside the left ventricular cavity, but with no obstruction. When we study the flow at the LVOT, it is normal with no late peak, but there are other interesting flows in case of hypertrophic cardiomyopathy. For instance, when we set the sample volume close to the left ventricular apex, there may be a flow like this one. Soon after systole, during isovolume relaxation, there is a high velocity flow going in the apical direction. The reason for this kind of flow is that the left ventricular apex is the first to relax in the patient with hypertrophic cardiomyopathy. And although both mitral and aortic valve being closed, there is movement of blood inside left ventricular cavity, since there is more tension in basal area than in the apical. Contrary to this flow during the isovolumic contraction, may have a flow moving from the apex to the base before the beginning of ejection.